Very interesting talks and also very interactive within the consortia that already existing. I mean, the DZKJ, German Center for Child and Adolescent Health, we are, from a pediatric perspective, we are still in infancy because we are just 10 months old, started last June. But several groups that are associated and integrated into the DZKJ have already worked on corona, COVID-19 infection for quite some time. And just to mention, there are a few differences between adults and children. The major difference was evident from the very beginning. We all were prepared that the hospitals will be flooded with severely sick children, as we see each year in respiratory syncytial virus infections, influenza infections, but that did not happen. So the clinical course is different in children than it is in adults. That also includes the long COVID situation. And I already mentioned, and also thanks to Hans-Georg Greuslich, who initiated together with me and some other people in Baden-Württemberg, one of the largest family studies also addressing immune responses. We clearly have shown and could see that in the families, the responses are different. The children, they make more antibodies, and what is more important, they make much more neutralizing antibodies. The response is sustained. They have a different response already in the upper respiratory tract with respect to innate immune system and interferon response, and that together may all explain the different causes. But nevertheless, there are, of course, situations where the infection becomes prominent and also be a disease with long-term effects. Most of the long-term effects, though, that we currently see have something to do with the social deprivation and the problem of closing schools for quite some time. And we have seen it also in terms of infection, because when the pandemic was over, we were overwhelmed by virus infections, severe virus infection in children, and the intensive care units in at least the southern part of Germany, we had really difficulties to distribute the children between the different ICUs because of the severe RSV infection wave that we had that was almost absent for 2 years. Now, with this introduction, we are already to the topic that is multisystemic inflammatory syndrome that was already mentioned during the discussion today, and Tilmann Kallinich from Charité will present the data.
Dear Professor Debatin, dear colleagues, thanks for inviting us for this very exciting symposium. I learned a lot, and I hope you get something from this talk. And it was already introduced by Christina Falk, the study which we have performed in a combined effort from the Charité and the DRFZ. The multisystem inflammatory syndrome, or MIS-C, was first reported in April 2020 by colleagues from Bergamo and London, describing an unpredictable accumulation of cases with a hyperinflammatory syndrome resembling Kawasaki's disease or septic shock. And these authors already described that the symptoms occurred 4 to 6 weeks after a mild or clinically inapparent SARS-CoV-2 infection. And this illustrates that the hallmark at that point was that people found a lot of cytokines. So it was a real hyperinflammatory condition affecting a lot of organs, different organs, especially the heart. And that led to that a lot of people needed supportive therapy on the intensive care unit. Some needed operation. It was really a dramatic time and a strong immunosuppressive therapy. So to elucidate a little bit the pathology, we started a multi-center study including 145 MIS-C patients around 4 centers in 4 continents. And we got excited about our first measurement of the cytokines and chemokines in the sera of this patient. What you can see here is that there is a strong elevation of Is there a pointer?
Hier, der ist der Pointer.
there's a pointer, sorry. That there's a strong elevation of TGF-beta in the sera of these patients. It's just comparable to the levels found adult patients on the ICU, but you see that the sera of influenza-infected children or adults with flu-like symptoms, we did not find an increase in TGF-beta. And this was particularly interesting since we were able to show previously that the TGF-beta levels are also associated with the impaired NK cell function in severe COVID-19, and it's a predictor to be admitted on the ICU. And others have shown that the N protein of SARS-CoV-2 can directly wire the TGF-beta receptor-induced SMAD pathway and the phosphorylation, and this is shown in this slide. Now it's not working. Okay, it's this slide, and you can see that just the serum of the patients with MIS-C induces actually the phosphorylation of SMAD2, meaning we are measuring the active form of TGF-beta and not the inactive form. To get a closer look into the immune pathology, we performed single-cell RNA sequencing on pre-sorted cell, meaning we sorted first by flow cytometry the activated T cell by the expression of CD38 and HLA-DR and the monocytes and the memory B cells of 11 patients with MIS-C and controlled it to children who had COVID and developed no MIS-C after 4 to 6 weeks. And when we looked at the UMAPs, you can see that there are changes in every compartment, meaning the monocytes and the B cells. But I want to focus on the T cells, since we found the most dramatic changes, and there were 3 clusters clearly increased. It's a cluster of the proliferating T cells and the CD4 positive and CD8 positive activated cytotoxic T cells. Now, the next question was whether actually the TGF-beta imprints these T cell population, and therefore we use gene set enrichment analysis, which were previously developed in this paper. And it's a gene set which shows the TGF-induced gene sets, and indeed, exactly, it overlays with the 3 clusters which are also expanded. They are imprinted by the TGF-beta. So next we want to functionally actually address whether we can measure this TGF-beta, has it an effect on the cells, and therefore we used the ARTE assay, and the ARTE assay took advantage of the expression of rapid expression of certain molecules after the T cell is actually activated via the TCR antigen specifically. And with that assay, we can measure the frequency of specific activation of T cells. And for this, we took the PBMCs, paired samples from MIS-C during the acute phase and in the follow-up when they were in remission, and we stimulated that cell with a cocktail of different viral protein, and then measured the frequency of stimulated cells. And you can see actually there is a suppression of T cell activation in the acute phase, which restores after the follow-up. The next question was, is this actually due to the TGF-beta? And for this, we took the same assay, but this time we took the PBMCs from healthy donors and added a sera from acute MIS-C patient, and you can see that again the activation of the T cell is diminished, but we were able to restore it by blocking the TGF-beta. So this shows that the TGF-beta actually has also a functional role by impairing the T cell function in acute MIS-C. So I switched gear. At the beginning of the pandemic, it was quite rapidly clear that by this publication that children with MIS-C express a certain beta chain in the TCR. It's the V beta 21.3 chain. And this is found in most of the children with MIS-C. It's actually a hallmark, and we can use it as a diagnostical marker. When we looked in our population, that's a population from Europe and from South America, we nearly always found it when we looked on all T cell, but if we just looked on the activated T cell, we actually found it in every child. And the next question was, does this actually overlay again with the increased cytotoxic and proliferating T cell, which are imprinted via the TGF-beta? And you see that this is actually exactly this population. So the next question was, what do they recognize? At the beginning, it was always thought it's a super antigen, but we didn't find, when we just took the SARS-CoV-2 into the culture, we didn't see that there was a vast activation of these cells. So we thought it might be also a virus, and then therefore we performed again this assay, this after-assay, using PBMCs, stimulating them with also the peptide pool of the viral peptides, did an enrichment, and then did an TCR sequencing. So we could sequence viral specific TCRs, and then we clustered them in this analysis together with the TCRs we found in the MESI patient. And you see that nearly all TCR which are specific for EBV cluster together with the MESI. That was the first hint that these cells actually are supposed to recognize EBV. We went back in the literature and found this paper where it was with the MHC class 2 tetramer technology, found that some patients with a mononucleosis actually have a higher expression also of this V-beta 1.3 chain, and this chain was shown here that it actually detects a promiscuous peptide from the EBNA2 protein, and this was only found in some of the mononucleosis patients, and we thought we'd bring this on a broader range and looked in adults who had previously been were infected with the EBV, whether the addition of these peptides in two different forms leads actually to the expansion of the V-beta 21.3 chain-bearing T cells, and we could find this in every patient, in every subject we analyzed. So this is another support that actually this specific peptide is be recognized. And I want to make the story short because we did some other experiments to prove whether this is really true, but we also could show, for example, that the V-beta 1.3 positive cells compared to the negative cells have a higher capability to lyse EBV-infected B cells and have a higher capacity to degranulate. So this is other supports that these are actually really directed against this peptide. So if this is true, we thought we want to see whether there is a higher prevalence of EBV seropositivity in the cohort, and this is the cohort, this is a pooled cohort from different countries, and this is actually a cohort, a pre-pandemic cohort from the Berlin-Brandenburg area where the seropositivity is shown, and we did a very careful age-matched control, but found that this is significantly increased in the MESI population. But to show more directly the EBV reactivation, we did another approach. We again collected the B cells and plasma cells from 35 patients with MESI and did another single cell sequencing, and every dot you see here is a positive cell currently transcribing the EBV DNA, and this is actually every third 100 cell, and when we compared it to severe COVID-19, a condition where it is known that EBV is reactivated, it's quite the same actually, but it's not true for adults which are vaccinated against SARS-CoV-2 or tetanus, and also not true for healthy controls or mild COVID-19 affected patients. So I want to summarize it. So the TGF-beta mediates temporary immune suppression and EBV reactivation, and we think the child is getting, probably with a certain genetic susceptibility and an infection with EBV. Later, it has a virus latency, but then it's getting infected with the SARS-CoV-2. It has this interferon gamma response, but directly through the SARS-CoV-2, also the induction of TGF-beta, which leads to a T-cell suppression and dysfunction, so meaning these cells they can't lyse infected cells, but they are still actively producing cytokines and chemokines, and therefore there is a reactivation for EBV, and then the T cell clone expanded, and the hyperinflammation occurs, making the child sick, like we have seen it during that time. And it has a potential impact also not for MESI, but probably also for severe COVID-19, and we discussed it before for long COVID and further other hyperinflammatory syndromes. And that is the most important slide showing all the people who are involved. And I want to mention Karl Götzger, clinical scientist who performed the studies and the first author, and the experiments were done in close cooperation with Mir Faschings-Maschregi at the DAFZ, in the third program area for systemic rheumatology, and also Pavel Durek performed all the biostatistical analysis. These are the national and international collaborations and the funding partners, including DZKJ, BIH, and the Leipzig Pandemic Preparedness Initiative. Thank you.
Yeah, thank you very much. Interesting talk and an interesting concept. I was actually wondering, I mean, the TGF-beta is something that we already also heard this morning already. When I think about the transplant patients, bone marrow transplant, severe immunosuppression, we see EB virus reactivation, but not regularly. So what controls it in that situation and is obviously not functional in the case of this TGF-beta? Maybe it's a TGF-beta storm that does, in addition to a global immunosuppression, has another effect on the cells.
But there must be another individual reason, that's for sure. Because we saw it at the beginning, every 800 child getting affected, later every 4,000 child. So there must be some other genetically cause which controls it in the, luckily in the majority of patients.
Okay, I don't see any more question. Everyone is already close to be exhausted, but there are going to be two other talks that are interesting in this session, and the next one is given by Ulrike Ravens-Sieberer from Hamburg, and is about exactly something that I already described, that is the consequences of the corona pandemic for children and adolescents during and after the pandemic, which is not so much addressing TGF-beta, but other things.
Yes. Dear colleagues, thank you very much. It's nice to be here. It's already late, but I would like to ask you for a slight change of perception, because I'm not going to talk about cells. I'm not going to talk about proteins. I'm a child public health person, and for the last 20 years, we've been interested in what mental health and also the quality of life of children in Germany, and recently undergoing the pandemic. And so I'm going to briefly show you some results on this. I'm going to introduce to you the COPSI study. COPSI is short for Corona and Psychosocial Well-being, and just after the pandemic started, we were able to relatively soon assess the quality of life and mental health in children and their parents and families, because we had been doing this for the last 2 decades in cooperation with the Robert Koch Institute, who also did a health and examination and interview survey on German children and adolescents, the KICS survey. Some of you might know this. So what are we interested in? So what were our research questions? We wanted to know what is the situation with regard to well-being and mental health in the German children and adolescents, and specifically, what impact do crises have on the mental health? So this is the health crisis like the pandemic, but also following crises like wars or financial crises. And then we also wanted to know, I have to put my glasses on because this is hard to see here, what are the main risk factors and which children are most affected, and also we were interested in what are the resources and the resilience factors and how can we protect children and adolescents from mental health problems. So here you see the timeline of the COPSI study. You see the baseline, which refers to data that were assessed 15 years before the pandemic, but continuously. And then we relatively soon started after the pandemic began. So the first time point was the first lockdown. The second time point was the second lockdown. And then we covered the whole range of the pandemic until the WHO said that it came to an end. And altogether we asked 2,800 families with children from 7 to 17 years old. And altogether we also gave 1,700 children a voice. So that was the longitudinal representative cohort study with the different time points. Now, I would like to draw your attention to the pattern of this line, because you can see that when the crisis and the pandemic began, relatively soon quality of life in the children declined at the first lockdown, and then at the second lockdown, and then while the pandemic continued, it recovered, but it never reached pre-pandemic level. And here I have some from these screening instruments which are internationally validated. I have just some sample questions, and this is also true for the screening of mental health with the strength and difficulties questionnaire we used. Here you see the same pattern. You see an increase in mental health problems, and then it increases even more, and then it recovers, but it also never reaches pre-pandemic level. So after this, we can now say that at the end of the pandemic, and even now, we have a lot more children that suffer from mental health problems. And if you even look more specifically, like for anxiousness and for depression, you see the same pattern with these lines, although a lower prevalence. If you look over the whole time points, for example, for loneliness, which is a strong indicator that has recently been discussed for the last 20 years, you can see that we started, and then you see the pandemic where loneliness increases in children and adolescents, and then it recovered, and then it decreases again right now, and maybe we can talk about the reasons for this a little bit later. So at the moment, it's about 21% of children and adolescents who report that they very often are confronted with loneliness. You could argue that this is an interview survey, and that might not be true for diagnosis reported by doctors. And this is why we have also looked at secondary data from the health insurance companies. And what you see here is that the waiting time for psychotherapy, for example, doubled during the pandemic, and that the hospitalization among adolescent girls, for example, for anxiety and eating disorders and also depression has been observed to go up and is almost double right now. We've often been asked how school closures have impacted this development, and with colleagues from the University of Constance, we did a study that could show that the impact of school closures on the mental health of children and adolescents is quite high. So they could actually show that each additional week of school closure led to a decline in quality of life and an increase in mental health issues like depression and also an increase in psychosomatic complaints. Now, as public health researchers, we are very interested to know which children and adolescents are most affected and which suffer most from the crisis. So there is a vulnerable group, about 17% of children and adolescents being at a high risk. And these risk factors are low parental education, parental mental burden, migration, and limited living space. So we could actually show that if all these risk factors occur, there is a 2 to 3 times higher risk for suffering from mental health. And so social status has quite an important role, and it might not be surprising that we see that in most of the children from a low social status, we see the most frequent mental health problems. So there is a social gradient that had been first described by Michael Marmot in the United Kingdom for adults, but it's also true for adolescents. We see that throughout the pandemic, we can see this social gradient, but we do not see that there's a widening gap after the pandemic. So it is quite stable throughout time. And also we've been interested in which are the resources and the resilience factors, especially at children with a high risk. And we see that there are some resilience factors, especially family cohesion. And if these apply, there is a 5 to 10 times reduced risk for those children that suffer from a high risk so that they are not affected by mental health problems. So the question is, now that the pandemic is over, is there a relief afterwards, and is everything good now? And what we see is that the worries continue, but they change. So the children and adolescents are not worried about the pandemic anymore, but there are other crises like climate change, like war, like financial burdens that have quite a high impact. And this is also in line, these findings are in line with a paper from the Lancet Psychiatry Commission on Youth Mental Health. And they examined the development of mental health in 5 different countries like Australia, like England, and others. And you can see that throughout all these countries, there is a rise of mental health prevalence problems for boys and for girls and for all ages. So this is very much in line with our findings in Germany. So what about long COVID? I've not talked about long COVID so far because it's a population survey, but what we have done is in 2024, we asked the parents whether the children had undergone a COVID infection and whether there is a diagnosis for long COVID. And what we see is that in our population, nearly 80% of children underwent the infection, and more than 8% of the parents reported that the children had been diagnosed with long COVID by a doctor. So the question is, does that make any difference in symptoms? First of all, we see that on average the children with long COVID are older and that they come from families with a lower socioeconomic status. There is no gender difference, and we see that they suffer much more from multiple health complaints like the ones we've heard about today already for adults. So this is fatigue, but it's also lack of concentration, it's lack of sleep and headache, backache, and others. So altogether, we could say that even in the population sample, our analysis show that the children with long COVID diagnosis have significantly higher mental health problems. They suffer more from depression, they show more symptoms of multiple health complaints, and they have a lower quality of life, but anxious symptoms remain the same. Now the question is, what were and what are the political reactions to this data, because we have been the first cohort study in children that showed that the pandemic had an effect on the mental health, and more than 1.5 years after the pandemic started, there had been the first reaction, like the German Ethics Commission said that there should be solidarity with the children who did a lot to protect the older people, and other initiatives. And just recently, child and adolescent health, there was more focus on child and adolescent health, why the German Center for Child and Adolescent Health was supported. And also just recently, last week, there was the first symposium on long COVID in children and adolescents, and there's a research network, and so I know that in the next talk you're going to hear about that and about long COVID in children and adolescents. And with this, I would like to thank you for your attention, and if you would like to read all the results, there's this QR code, and I hope I haven't used my time up. Thank you.
Actually, in one of the data, we have shown that feeling lonesome during the was data from during the
Loneliness.
pandemic is much more pronounced in girls than in boys.
Yes, and depression also. So that what we see during the pandemic is that especially girls got hospitalized more in child and adolescent psychiatry due to depression and eating disorder.
Christine.
Thank you very much for the COPSI study in general, because I think this was really the first highlight that how the children and adolescents were reacting, and that they have really such a lot of socioeconomic problems was underestimated. So this is my first comment. My question to you is, you showed your survey in 2024, and you showed that only 80% were infected. Is that monitored at the moment? Because I think that basically it's sort of whether the children are tested for SARS-CoV-2 or whether it's just a normal flu might just depend on, I don't know, maybe just personal preference. So how do you know? Because my perception was that maybe all of the children at some point at least get infected once, but I'm not sure whether this is...
Yeah, absolutely right. Yeah, we would love to know that in more detail, but that was not possible within this survey. This is just parent-reported, administrated prevalences. So we need to rely on the report of the parents. But you're absolutely right. We would love to have had blood samples.
Stefanie Dimmler.
I learned before that the respiratory viruses are even more harmful for children and being focused on COVID, but what is the effect of these infections? Is there a difference in the perception also of these infections?
In the perception of these infections? I'm sorry, it's so hard to hear up here. Sorry.
Yeah.
So the respiratory viruses, I learned from Klaus Debatin in the coffee breaks, are much more severe from the pathophysiology, means that the symptoms and all, but they seem to be not investigated.
Yes, absolutely.
COVID is of course something everybody talks about or was talking about.
Yes.
While a severe infection is just, you have a flu.
Absolutely.
So maybe it's just also the perception of the children which makes difference, not the pathophysiological impact. This is what I wanted to...
Yeah, you're absolutely right. The thing is that we looked at COVID and we looked at the COVID infection and could just take the reported outcomes. But what you say is really a plea for a much better health monitoring in children and adolescents. So this is hopefully going to be set up within the next couple of years by the Robert Koch Institute, and then these differences can be made. It's just not, with our study, we were actually happy that we could start at the first lockdown because we had the measures in place, because we had been doing it before, but it's not such a general health survey that we could conduct. But you're absolutely right.
Perception clearly plays a role. In our Baden-Württemberg study, we have analyzed 1 year after primary infection the families. And the symptoms, broadly considered long COVID, in the families match between adults and children. So if the adults have reports a pathology, children tend to report also the pathology. So there seems to be an effect. I mean, you can argue it's the virus that spreads within the family, but it's even children that have not been infected report on symptoms, so there is something going on in addition to just virus and TGF-beta and cytokines. Okay, thank you very much, Helene Ulrike. We're coming to the last presentation. By Nicole Töpfner from Dresden, who actually catches up in setting up a study on long COVID in children, just started, BMBF funded.
Thank you very much, and I'm happy to talk today about pediatric long COVID. And I'd like to hear a bit more about your background. Who actually is involved in pediatric long COVID care? Maybe can you just lift the hand? And who is involved in pediatric long COVID research? So maybe there would be many opportunities to cross-link this in future so that we come in interaction with each other. As you maybe all remember, it took very much longer for the WHO to define long COVID, a post-COVID condition in children and adolescents compared to adults, because it was finally fixed in February 2023 based on an expert consensus, so that symptoms occurred within the first 3 months after confirmed or probable SARS-CoV-2 infection and have persisted for at least 2 months. So it varies a bit from the adult definition. Here you see data from the UK Coronavirus Infection Survey, self-reported frequency of long COVID in children, and you do see that the young adults reported a frequency between 1 and 1.5%, whereas the adolescents are around 1%. And frequencies between 0.2 to 0.3% of people reported significantly restricted daily activities. This age dependency was actually confirmed also by the US-American data, so that in the pediatric cohort, the young adults and the adolescents were mainly affected by long COVID. And these are data from our German cohorts, derived from the pediatric part of the Immune Bridge project of the Network University Medicine. Here the CORKID cohort from North Rhine-Westphalia, presented by Jakob Höppner. So that at least if you take all symptoms together, there was a differences if the children were either vaccinated or infected by SARS-CoV-2 measured by antibodies in comparison to children without any SARS-CoV-2 contact. In a time where this was still in discussion if long COVID actually exists at all in children and adolescents. Here are data from Dresden and the Pointed Consortium, Jochen Schmidt, and our pediatric approach to assess the relative risk of symptoms 3 and 12 months post-documented diagnosed SARS-CoV-2 infections in a very, very large control-matched study. But now I'm from pediatric in Germany. So based actually on the Cover Child project in the network University Medicine and on many roundtable discussions, it became more and more clear and consented that the prevalence in children and adolescents of pediatric long COVID was lower, but with a higher vulnerability, because the adolescents were mainly in the stage of qualification for final exams, for university degrees or jobs. So there were special psychosocial needs, but also existing special care structures, e.g. the social pediatric centers exist in pediatrics who could care or offer care for the severely affected adolescents with long COVID and ME/CSF. So, based on a call of the Bundesministerium für Gesundheit on the model approach for long COVID, beside 3 other pediatric projects, PETNET LC got funded by 41 million euro, headed by Uta Behrens and me as the co-leader. And by now, PETNET LC aims at a pediatric network for the care and research of post-acute consequences of COVID-19 and similar post-acute infection and vaccination syndromes and ME/CSF. So just 3 days ago, there was a kickoff of PETNET in Berlin, and we just start the establishment to achieve a timely, customized and sustainable state-of-the-art care for children and adolescents with long COVID-like illnesses through the use, evaluation and further development of knowledge, experience and infrastructure. PETNET consists of 20 CCCs, comprehensive care centers, with pediatric and child and youth psychiatrists involved, 2 pediatric pain clinics, 3 pediatric rehabilitation clinics, and 8 research institutes. And there's close synergy and involvement of healthcare providers, GPs, outpatient pediatricians, specialized association, professional associations as the BVKJ, the DGKJ, DGPI, patient organizations and foundations. Here you have an overview about all involved clinical and scientific partners, and there are a lot of the partner sites of the DZKJ also involved, and all DZKJ partner sites are involved to make up the base research and care structure for chronically ill children. There are also synergies with other DZGs like DZIF, as PETNET is actually based on the IMUC cohort of Uta Behrens, founded in DZIF long time ago. What is the focus of PETNET now? So we will focus from the pediatric side on complex long COVID with participation deficit, especially PEM and ME/CSF. Just to give you a short glimpse of the work package, beside general coordination, of course, there will be a huge package on patient, parent, and public involvement. We will set up a national CCC based on evidence, research, and knowledge translation to design FAQ sheets specialized for adolescents and young adults, SOPs, guidelines, education programs for staff, teachers, and patients. And we will perform a nationwide expert board for very complex patients, which are also discuss the need to differentiate it from child abuse and all other conditions, sometimes mixed up with a clear case definition of long COVID and ME/CSF. So there will also be federal and local CCCs established to adopt the local care to the national standards. There will be a huge school project involved to early assess the school attendant problems and to optimize it. There will be a telemedical infrastructure with existing structures established and specialized for long COVID care, so cross-sectional the PET expert of the outpatient pediatricians and intersectoral between each other by telemessenger. There's a huge research infrastructure started to be established or already established and optimized now, so with this, that each study center, so each CCC will include all pediatric patients by the same case definitions into the register. And there will also be a biobank adapted to this register, where we are already in exchange with the DZIF SOPs and the DZL SOPs to also make a homogeneous biobanking for the children and adolescents. There will be a huge opportunity for register-based studies. By now planned, there will be a study on breathing disturbance and sleep disturbance on CMRIs and genetics. There will be the perspective of healthcare providers assessed and health economic analysis by linking the register and health insurance data. So furthermore, we also focus on synergies deriving, e.g. from the Baden-Württemberg funding, which Debatin mentioned, or the funding in Schleswig-Holstein and Bavaria, or the Innofond project Kids Care PVS. So with PEDNet LC, we aim on the dissemination of results and sustainability. We like to establish and maintain a cross-sector interdisciplinary interprofessional care network with reusable research and supply data and interoperability. We will provide information materials on long COVID and recommendation for actions in pediatrics and aim on nationwide health literacy for actually in the end hoping that we'll find the best and effective treatment for adolescents suffering from severe forms of long COVID and ME/CSF, to then go into discussions with social insurance providers that they maybe implement this in standard funding sometimes in future. So I thank all of the people involved in PEDNet and the other pediatric projects in the BMG consortium now, and I'm happy to take your questions.
Thank you very much. So you appreciated that this has just started, but will be definitely an enterprise where we then get more information than what we already have on the long COVID situation in children and adolescents. Questions, comments? If not, then thank you very much again. Thank all of you for contributions of the day, and I hand over the mic now to Stefanie.
So thank you very much. We just need to prepare for the panel discussion. Let me thank all the speakers for the scientific sessions. And now in the last half hour, we will have in German a discussion with our patients. Dann würden wir auf Deutsch wechseln. Und wie gesagt, ich würde zunächst ganz herzlich unsere Panelists begrüßen und vor allem Frau Theobald, Johanna Theobald. Sie studiert in Mainz mit Medizin. In welchem Semester konnte ich jetzt nicht rausfinden, aber das erzählen Sie uns vielleicht noch selber.